And we would like to move on to the fourth speaker, Dr. Samuel Gidding, a professor of genomic health at Geisinger. He has an over 40-year career in preventive pediatric cardiology. Since retiring from clinical care, FH has been a research and advocacy focus. His research focuses on implementation of FH screening guidelines and incorporating genetics into risk assessment and clinical practice. Dr. Samuel Gidding, please.
Thank you very much. It's a pleasure to be here and giving this presentation. And what I would like to talk about is something that we actually don't talk about as much as we tend to talk about the hypercholesterolemia, but we do not talk as much about the familial hypercholesterolemia. And I would like to go over what exactly that familial means in practice. Are my slides projecting okay? Okay. My conflicts, I'm a consultant for Aspirion, and I have a number of NIH grants related to FH. So the FH treatment message is...
Sam, you can make it bigger.
Make it bigger. Let's see. Okay. The current FH treatment message, and this is kind of the way I think we were taught, is you have high cholesterol and it causes heart attacks. You will need to take medicine to lower cholesterol to goal for the rest of your life. If you not take this medicine, you'll have a heart attack and you could die. And your children or future children could have the same problem. However, there are difficulties with this type of message, is that not only is high cholesterol the only cause, but there's not the only cause of heart attacks. And then you will need to take medicine to lower cholesterol for the rest of your life. But what if you have no measurable atherosclerosis? Or what if there are other high-risk scenarios in your life that are more important, and you're concerned that you might actually not live long enough to have that heart attack? You could still, even if you take the medicine, you could still have a heart attack and die. And your children also might not have familial hypercholesterolemia. So we give this message and it seems true, but it's not as true as we think it is. So we're all familiar with the pedigree for heterozygous and homozygous FH, where in heterozygous FH, it's passed generation to generation. And in homozygous FH, there are multiple affected family members with both homozygous and heterozygous FH. However, that is not the reason I'm showing the slide. The reason I'm showing the slide is that every one of these FH patients has multiple affected family members at different points in the life course, and they are reflecting back on the experience of their family members with FH and how it might impact their lives personally. And in each of these generations, the questions about FH care and FH care inheritance are actually very different. Also, when the patient comes in your office, they really are more concerned about maintaining health than preventing disease. Any FH patient, particularly the younger patients that Bert and I see, are healthy, and they want to continue to be healthy, and they want to continue to do the things that that they're currently doing, and don't see any reason why they cannot. And in many cases, that's true. So for the younger the patient, the more the care is actually about health rather than heart disease. As I mentioned, all patients have affected family members, and those family experiences with heart disease or without heart disease, with and without medication, all influence care. Every family has someone who might or might not have an adverse drug reaction or have drugs that they felt worked. or not had a heart attack and wonder what you're talking about. I talked about the idea that FH impacts a person differently at different stages in the life course. And as Bert has discussed very effectively, FH risk is related to chronic exposure to elevated LDL. But our treatment guidelines and recommendations focus on a specific point in time. So when the patient walks into the office, we're concerned about getting the patient to goal, whereas the patient is actually concerned about the remaining 20, 40, 50, or 70 years of their life. So that's a very different focus of the physician who wants to get the person to a specific LDL target and the patient who's thinking about their entire life. So here, this is a paper that is submitted at Journal of American Heart Association. This is a figure from this table, but this figure is meant to show the diversity of interests and concerns across the life course and the diversity of people with FH. So no approach to any FH patient should be the same in the same two patients. During pregnancy, we need to do genetic counseling, screening of progeny, and alter care. In younger people, we're talking about early lifestyle interventions, making sure they never smoke, diet, and a family focus. And we may initiate treatment if LDL cholesterol is extremely high, particularly if the patient is homozygote. As people age, we do a more global CV risk assessment, continue with diet and behavior, and initiate treatment for most patients, and we'll also be cascade testing relatives. Then we have to worry about the transition of care to adulthood. Who's going to take care of the patient as an adult? And will the patient actually go to the doctor as an adult? Further CV risk assessment and lifestyle management, though this changes because people are older and more responsible. And then we may need to treat the LDL cholesterol to a lower target. Bert mentioned 3 millimoles per liter as a key threshold in children, but in adults, it's about 2.5. And we want them to continue to take their medication. And then the next big thing that can happen is actually a heart attack. And if the heart attack happens, that's another transition point in care, an additional burden on the patient. And then we get to adulthood, and now a new problem or new concern has raised in FH. What do you do with a person with FH who's over 70 or 75 and has not had a heart attack? Do they need as intense treatment, and how should that treatment be stratified? At a personal level, these same people have tremendous other influences beyond the physician's office in their lives. And they include the family, affected and unaffected members. And I don't think we pay enough attention to the unaffected members who often are responsible for helping the patient manage care and get the patient to appointments, and who can be worried about the patient because their lifestyle, their income may be dependent on that particular individual. We've talked about pregnancy, issues of inheritance and cascade testing, how you manage healthcare, psychological support, and shared experience. At the society level, depending on your age, what requirements are at school, at work, in the community, your health insurance, economic constraints, cultural norms, and attitudes towards genetic conditions all may impact the patient with FH and their concerns and how they respond to your treatment recommendations. And finally, the healthcare system. Does primary and specialty medical care exist for FH? Is it appropriate? Is the knowledge level appropriate so the care itself is not a barrier? We see, patients being told, oh, you're a woman, your cholesterol isn't high, You don't have to worry about it. And so there can be competing opinions and barriers within medical care. Is there access to genetic counseling, to pharmacy support, and do the other resources that are necessary for FH care exist, and how costly are they? And how accessible and FH friendly are they? All these issues impact the care of an individual patient. So the treatment dilemma, here's your lipid profile, L total of 280, triglycerides of 60, HDL of 40, LDL of 225, fairly straightforward. But should the same patient get the same treatment at age 20, 40, and 60 years of age? And here I think is the dilemma we face, is the guideline for treatment for each of these patients is exactly identical. But again, if we go back to the material that Bert has presented on chronic exposure, should their treatment be the same? Should the 40-year-old be treated more aggressively than the 20-year-old because of twice the life experience with elevated cholesterol? And how about the 60-year-old who's gotten to 60 without a heart attack? How should we treat that patient? Does that where does that patient sit on the spectrum? How can we answer these questions independent of our existing guidelines? So here's the model for chronic exposure. I think this slide is in most people's slide deck of those who care for or give talks about FH. And it shows the different ages at which you can reach the chronic LDL cholesterol exposure and put you at risk for heart attack depending on your situation. Homozygous, 12 and a half years. Heterozygous, untreated, 35 years. Attenuation by treatment, if treatment is started in young adulthood or childhood, with the best result being treatment from childhood. And if we treat to Bert's new targets, maybe even better. And then age 55 years in the general population with an impact of other risk factors on the outcome. So it's this model. What we really haven't understood yet from this model is how to incorporate this idea of chronic exposure into the type of treatment that we provide. So I'm proposing in this talk, though we don't have the data yet to make these recommendations, is to base treatment on lifetime risk, considering both LDL-C and additional risk factors and that chronic exposure. We want to intensify treatment in those with the highest chronic exposure. Ideally, we would like to monitor atherosclerosis. And then we want to allow for variable treatment or varying goals based on patient needs and more precise risk assessments. Can a patient have a drug holiday, for example? We now know during pregnancy, because of restrictions on medication use, that we interrupt treatment during pregnancy. But suppose a patient says, I'm tired of taking my medication, can I take a drug holiday? How do we make those recommendations? How do we compensate for that chronic treatment? And is treatment every day of your life really important if we can monitor atherosclerosis? So, can we monitor atherosclerosis to further guide and risk stratify? So what we need is a perfect imaging tool, which is minimally invasive, applicable across the life course, and measures coronary atherosclerosis. Right now, we know that that tool does not exist. The current tools include coronary artery calcium score, which is appropriate for adults because of the radiation risk. A limitation of the CAC score is that calcification develops in the fourth or fifth decade, so you really can't use it, certainly in childhood for that reason as well, and you may have false negative tests in younger people. However, Once you hit age 50, a CAC score of 0 may be extremely helpful in stratifying risk because those people are unlikely to have an event in the next 15 years. Carotid IMT has been used highly effectively in research studies of populations of people with FH, but unless you happen to be in the Netherlands, it can be imprecise and can be technically difficult. When you have a highly skilled laboratory, such as with Dr. Wiegman, and you can be confident in your measurements and the change in measurement over time, it is can be a very useful monitoring tool, and showing the failure of IMT to progress can be an important demonstration of successful outcome for patients. However, as yet, it's not generally applicable. Another limitation of IMT is you have to use age-specific thresholds because IMT increases with age. On carotid IMT, however, in adults, if you see atheroma, this obviously has important implications. MRI is potentially useful for imaging the aorta, which can, aortic atherosclerosis, particularly in the abdominal aorta, can correlate well with coronary atherosclerosis, but there's been limited research on this, requires use of the magnet and cost, and not everyone is comfortable getting an MRI. Coronary CTA meets most of the criteria of a perfect imaging tool. However, there is radiation risk and it is somewhat invasive, and you can have false negatives. However, the older you are, the more, and if you have HoFH, the more reasonable a coronary CTA becomes for monitoring. Now, one thing we don't do is family-based clinics. Though FH is familial, we do not see multiple family members at the same, we tend not to see multiple family members at the same visit. I think this might help us actually to get a sense of the family and to be able to care across generations and to get into the personalized aspects of care, which may improve adherence. It creates an opportunity to discuss the impact of social determinants of health on care, to address family fears and concerns, to address issues where within a family, people may have differing opinions about FH and what it means. How do we resolve those differing opinions? I think it may be important for adherence. It may facilitate genetic testing of relatives of index patients. It also is an opportunity to educate unaffected family members. Not everyone who comes to the office has to have FH. It can also include those people who are responsible for the care. Most importantly, it's an opportunity for the medical care team to better understand patients and their concerns, their cultural beliefs. Oops, I didn't want to do that. Okay. All right. So the next important thing in thinking about the familial hypercholesterolemia experience are transition points. And the first one is from childhood to adulthood. So what are the goals of the transition of care from pediatric provider to an internal medicine provider? Most importantly is education regarding FH. If the adolescent understands FH, this can give the child a sense of empowerment in independence and may improve adherence. Social awareness. What are the implications of an FH diagnosis for the child? Make sure the child or the adolescent understands these. And then you want to make sure there are appointments with providers of adult care for the child. Make a smooth transition so that care is seamless and the general attitudes towards care are relatively similar. Finally, there's psychological support. This includes how to protect the child against peer pressure. Let's say, why do you have to take a medicine? Why can you not do this? And also psychological support for managing a lifelong condition which other people don't have. The next key transition point is pregnancy, and we've discussed this a little bit already, but here is an opportunity for genetic counseling to test the unaffected spouse, for a complete risk assessment for the fetus, to assess heart disease risk at the time of pregnancy. It may be an opportunity for cholesterol screening as well in unaffected individuals. And you may be able to diagnose FH at the time of pregnancy. You're going to need to adjust medications to those approved in pregnancy. However, you still need to consider statins in high-risk situations and apheresis in very high-risk situations. And then you're going to need to provide counseling regarding breastfeeding post-pregnancy. The third key transition area is a cardiac event. This dramatically alters the type of treatment a patient will receive. First, there's acute treatment for the event, then there's rehab, then there's the potential for major lifestyle changes, physical activity, work restrictions, impact on the family and the family's source of income and resources. And medication targets are different. Plus, there are now new medications that must be added to as typical post-myocardial infarction treatments. So again, this is an adjustment, but it's an adjustment not just for the patient, but for the patient's family as well. And then resilient FH, which we can define as adults greater than 70 to 75 years of age without an event. This type of person generally has lower risk on a lifetime risk assessment, either by lower LDL-C exposure or lower overall heart disease risk. And how will we adjust medication and targets for the remainder of the life? Here again, may be a big role for atherosclerosis risk stratification. And it becomes an opportunity for individuals to study who don't get events. Why are these people protected? What is different about these people who get to this older age without an event than people who have events at younger ages? Now, I think an argument against this talk where we don't have a lot of data to answer these questions. So I've taken the liberty of raising some of them. These are our current research gaps. Though we know about the chronic exposure model, we don't know the exact age to initiate treatment in each patient and how this could be personalized. We need to learn more about the role of risk stratification and the importance of varying treatment goals based on this risk stratification. We need to know a lot more about pregnancy management, particularly which medications are truly safe and which ones truly are not during this time. Are there ways to integrate atherosclerosis imaging into care? This is, I think, going to be a major focus of research in the next 10 to 15 years. Can we predict who won't have a heart attack or resilient FH? And then we all know that we have a huge gap in implementation because most of our patients remain to be diagnosed, but also and some of these barriers exist at the societal level, at the healthcare system level. They relate to medication adherence, and they relate to failure of successful care transitions at the points that I discussed. Oops. So this, I would like to end with what I think is the familial hypercholesterolemia message today, is you have high cholesterol and you might have a heart attack, but it can be prevented. Lowering your cholesterol will keep you much healthier. We can provide medicines to lower your cholesterol and monitor your risk for heart disease, and we can keep your family safe by finding out if anyone else is affected. Thank you very much.
Thank you very much, Dr. Gidding. And you mentioned so many important points to take care of FH patients in each generation. And do you have any comments or questions? Bart?
Yes. Thank you, Sam. Wonderful overview. I do know that you have a vision of have had a vision of treating patients with FH once per 5 years for an intensive year, and then perhaps a few years no longer. How, with a cholesterol year score in mind, is your vision on that?
Yeah. So I think for younger people, I think we have to remember that the disease is atherosclerosis. If you start with the idea that the disease is atherosclerosis and that a heart attack is simply a consequence of that disease, that's where monitoring atherosclerosis becomes critical in management. So I think if you can aggressively treat someone so you can effectively clean the blood vessel, which you really have to do at an early age before you get fixed plaques. And as you've dramatically shown, for example, in your homozygous FH case, then you can start thinking about intermittent treatment. Obviously, in a homozygous case, the goal would be, as you've shown in your case reports, of cleaning blood vessels, because if you stop treatment in that scenario, it's going to come right back. And I think your more recent research suggesting, below 3 millimoles per liter, or 120 or 130 milligrams per deciliter, is good or effective at a young age, is extremely helpful in getting us to this idea. I think the key question is reversibility. And as I said, the younger you are, the more reversible. If you have a good imaging tool and can show that you've cleaned the blood vessel, then I think, sure, you can stop treatment. And when it comes back, the atherosclerosis comes back, you would then treat again. And presumably it would still be in an earlier stage and be just as reversible. So that's kind of the ideal. And it comes to the idea of treating atherosclerosis rather than preventing heart attacks. I don't think the entire medical community is there philosophically with that yet. But there is an NIH initiative now, and there will be a trial in younger people, not with FH, but in the general population, to demonstrate this hypothesis. We just actually sent in our application. I'm sure it'll be a big competition. I'm not sure who's going to get the award, but we're trying.
Thank you.
And David?
Yeah, thank you. Very important point, I think, is the family-orientated clinical service. And it's ironic in South Africa, where we have so much familial hypercholesterolemia, that when this condition was recognized as a serious condition in the 1970s, we had the scope to do pedigree tracing. We had the scope to have the family together, and yet there was very little treatment available. The cholestyramine was about the only recourse, and some dietary manipulation, which people thought was rather futile. But since the 1980s, we've had a withdrawal and a change of control of such services. So today, unfortunately, we no longer have a family-orientated approach for these metabolic errors. And we notice that we fail in pedigree tracing. We fail in dealing with the parents very often when we see the child as a pediatric clinic referral. And the point we always make when we see the children is that the parent that is affected is much closer to a coronary event than the child. In fact, the risk is much higher. It's while you need to focus on everybody, the worry is really the parent to be there for the child and to remain healthy. So, and our healthcare system is very much divided into a public healthcare where other competing interests quickly override, and the private sector control, which is a minority, but there's tight financial control, and we do not do justice to treating this very treatable disorder. Heterozygous FH is large numbers and big money when one deals with complications. Homozygous, although per patient it's very expensive, there are very few patients, and the risk is so extremely high that the benefit is remarkably obvious.
Thank you. I actually, that point about the parents staying safe, I'm going to add into the talk. I mean, that's something which occurred to me a long time ago when I first started and, trying to convince families to for the kid to take medication. And I would often encounter a scenario where the father felt it was important to protect his child, but he didn't need to take the medicine himself. And so kind of getting that message across was important, and actually it was the subject of my very first FH paper. So, but I'm going to add that into the talk. That's a great point.
And next, Dr. Ogura.
Yes, thank you. Thank you, Dr. Gidding. My name is Ogura from Japan, and I have a question about pregnant problem. And do you have any criteria for performing coronary CT in pregnant female FH patients?
I may defer that one to Bert. I haven't been practicing for a while, and I took care of children rather than adults. I think it's an interesting question. You probably might want to know in someone who's pregnant, but then because the person is pregnant, you may not be able to do it because of the radiation risk. So I think I would say that to give you a bigger picture, I think if you're over 40 years of age, that we ought to be using this test a little more aggressively because it's not, I mean, it is quote invasive, but it's a lot less invasive than it used to be, than just getting a regular coronary angiogram. And so I think if you have someone with very high lifetime exposure, I think it's important for risk stratification. And I think the older you are, let's say over 40 or 45 or 50, the more it becomes, the optimal test. I think the key limitation, and this comes from my work with the PDA study, is that the reality is that people that doctors think are high risk, only about 40 to 50% of those people have as much atherosclerosis as we think. About 50 to 60% have less than would be predicted for the amount of risk factors they have. Now, obviously, having 40 to 50 is also a very big number. And, so that it becomes important to identify them. But I think how we risk stratify and how accurate are our risk scores in predicting these people. I know PDA is fairly accurate, but I wouldn't extend it much beyond age 40 because it was developed in 15 to 34-year-olds. I think in adults, we have risk calculators and everybody gets all excited about them, but the reality is their C statistic still isn't much better than 0.72 to 0.75, which it's precise enough for clinical care, but we really don't know, it's also not great. So for ultimate precision. So I think if the test could cost less and be have less hazardous, we could use it more. And I think we'll get better at it as we move along and we have more trials that incorporate CTA into risk stratification, and that may help us be more precise in how we use it.
Thank you very much.
The only thing that I can add is that we don't use it in pregnancy because of radiation, but we do use it in young children. The low radiation dose CTCAs with EKG triggering, they have hardly any radiation. So you can use it in homozygous FH children already from the age of 3.
Thank you.
Any other questions?